It underscores the importance of understanding and addressing cultural beliefs and practices within the healthcare settings to effectively manage and mitigate parent anxiety during medical treatments. Third, the influence of mainstream cultural alignment on pain perception. Our findings suggest that parents who identify more closely with mainstream North American culture tend to perceive a little bit less pain in their children following the needle procedures. And this observation is sort of what we expect, that cultural alignment may influence perceptions about medical processes, and that could be due to varying levels of trust and familiarity with the medical system, medical processes. Finally, just cultural identity and overall concern. The results show that while mainstream cultural alignment has an apparent impact on both perceived child pain and post-procedure worry, heritage culture specifically influences only post-procedure worry. So this is just obviously a complex result, but it just shows how different aspects of cultural identity affect parental concern, which again calls for further research into the nuanced roles of various cultural elements and how they play into pediatric healthcare interactions. So to conclude, our research found that parental acculturation, particularly the alignment with mainstream or North American culture, significantly influences how parents perceive and worry about their child's pain during procedures. To wrap up, because I hope I'm good with time, I just want to acknowledge the participants who were part of this study, my lab, of course, and specifically Lo Jane, who helped me put together these slides, but is also working on publishing the paper with these results. And of course, the grants and awards that support this work. Thank you.
Any questions? Did you collect information on the background of these families? How was the diversity of your sample, and how do you feel this relates back to your results?
That's a good question. I personally do not have access to those demographic information. I do know it was varied in terms of those 4 buckets. We did have a lot of variation and a sort of even distribution of the marginalized, separated, integrated groups. I don't know specifically which countries people were from, or even within acculturation. We're saying North American culture, but people can interpret it differently. Somebody could be from Northern Canada and not feel culturally aligned with what we call North American culture. So I don't know exactly, but it is a good question, good thing to consider. Thank you.
Wonderful. So I'm going to be talking about age and sex differences in 2 specific types of pain, neuropathic pain and complex regional pain syndrome in children. You heard from Dr. Berner this morning, this constellation of biological, psychological, and social factors, or a BPS developmental model, that can influence a child's pain experience. And then these factors can also intersect with age or sex differences in pain. We know there are physiological and anatomical differences between the sexes, that socialization changes drastically from toddlers to school-age children, and that there's this really significant cognitive developmental leap throughout childhood into adolescence and even early young adulthood. And so it's not surprising that the prevalence of pediatric chronic pain differs between sexes and ages. So even though 1 in 5 children will experience chronic pain, it's higher in female adolescents, but not always. So when they looked at musculoskeletal pain and chronic back pain, there were no sex differences. And that's some of the most common types of chronic pain in children. And this review wasn't able to look at all different types of pain, and they couldn't look at neuropathic pain and CRPS. These are less common pain conditions, but they're really difficult to diagnose and treat. And so they account for about 1/3 of referrals to our pediatric chronic pain clinic. And so our team conducted a scoping review to really understand whether there are any age and sex differences in these conditions, specifically with the incidence, prevalence, and even the symptomology. And so neuropathic pain arises from a direct lesion or disease of the nervous system that has specific pain quality descriptors and sensory changes associated with it. CRPS arises from a dysfunction of the nervous system rather than direct damage or disease, but it shares the same pain quality descriptors and sensory changes as neuropathic pain and has additional non-painful symptoms like autonomic and inflammatory changes. And so when we looked at the literature, we found 87 different studies that looked at age and sex differences in these two conditions. And of the studies that looked at neuropathic pain, it spanned 19 different etiologies or neurological lesions or diseases. So really sort of a diverse set of literature. And although we found a handful of population-based studies that looked at pediatric neuropathic pain, they were looking across the lifespan. And they looked at etiologies that are peaking in adults over 75. The incidence is really low in children, so this isn't informative data for us. What's more informative for our pediatric cohort are disease-specific studies. And so when we think about phantom limb pain, so in children with some type of a limb deficiency, so whether it was congenital or trauma or surgery, the prevalence of phantom limb pain is up to 86%, so really high rates. With Fabry's disease, the prevalence of painful polyneuropathy, so burning pain in the hands and feet, was up to 67%. And in children with cancer, the prevalence of neuropathic pain was upwards of 44%. And when they looked at whether these rates differed by age, a number of studies were reporting higher rates in adolescents and sort of hypothesizing that maybe, they have more severe disease as they get older or the onset of diseases later in adolescence. And so they're more likely to experience neuropathic pain. But a whole bunch of studies says actually there was no age difference in the prevalence of neuropathic pain. So not so clear cut. And the really challenging piece about this is we don't have a good way to measure neuropathic pain in young children. So we're probably underreporting their experience of this pain. When they looked at whether there were sex differences in studies of children with Fabry's disease, males did have higher rates of neuropathic pain, which is not surprising because it's an X-linked disorder and males have more severe disease. Studies that looked at sciatica or trigeminal neuralgia, females were reporting this more commonly. But again, a whole number of studies were reporting there were no differences by the sexes with respect to the prevalence of neuropathic pain. So not sort of so clear-cut as we initially would think. There were two population-based studies that looked at complex regional pain syndrome. Both of them were reporting that the rates were higher in adolescents, and our study here in Canada reported much higher rates in females, which is what we see clinically. And in these studies, we tried to look at whether there were any differences in their symptomology, but so few studies are examining this. So we sought to look at this in one of our studies. Our primary aim was to validate a self-report screening tool. And in this tool, it lists a whole bunch of different symptoms of these two conditions. And it was a large multi-center study. So we had over 100 participants, 80% were female, and they were predominantly adolescents. So we were limited in looking at age differences. But when we looked at sex differences, we tried to look at whether there were any differences in pain intensity, pain interference, or the total number of symptoms that they endorsed. And there wasn't any significant difference. We took a bit of a deeper dive and looked symptom by symptom. Were there any differences by sexes? And there were sort of two symptoms that maybe females were endorsing more. But because the proportion of males is so low, it's really challenging to understand if there is a true difference. So not an easy task scientifically. And so sort of some of the key messages that we learned from this research was it looks like CRPS in children is more common in female adolescents, which is what we see with most of the other pain conditions, but it seems to be more complex with neuropathic pain. It might be more common in adolescents, but it's really difficult to measure in children. And what we see with sex differences in neuropathic pain might be confounded by sex differences in the underlying neurological lesion or disease. So what's another take-home message for me, in order to move this field forward, we have to be defining, reporting, and analyzing these variables. Similar to Dr. Berner this morning was saying, we are presuming that they're reporting sex differences based on how they're reporting this in their studies, and no one is really measuring and reporting gender in these studies. So some take-home messages for all of us in the pain research field. Thank you. Happy to answer any questions.
Thanks. That's really interesting. I'm curious with the symptom by symptom data, if you think there is a possibility for like a gendered socialization effect in what language we use to describe pain experiences.
Oh, that's a really good question. We did not specifically look at that. When we created the tool, we interviewed participants and asked them to review the language. And yeah, that would have been something that we could have delved deeper into in the cognitive interview study. So thank you for that.
Yeah, I'm thinking about some of the, I briefly mentioned it this morning, but some of the work from Melanie Knoll's group about how pain is depicted in children's media. And there's like a lot more violence associated with pain that boys are experiencing. I'm just wondering if that might translate into some of the language that we use and we kind of assume are like neutral clinical descriptors, but I don't know. I don't know if we know that.
That's a good point, because in our tool, we have a lot of like examples of what the pain might mean and whether there are any differences between gender roles and how they interpret that. So yeah, that would be an interesting next thing to look at.
Okay. Hi, everyone. My name is Hannah, and I work with Mike Salter and Ben Steinberg here at Sick Kids, and I'm excited to tell you about our neuropathic pain research. So I'll start by talking about an ongoing translational problem in the field of neuropathic pain. So we now know that there's an essential neuroimmune component of neuropathic pain, and the majority of research in this area has focused on the role of microglia, which are resident immune cells of the CNS. However, despite this ever-growing body of research, microglia targeting therapies have failed in the clinical setting, and so we still have a substantial disease burden on a personal and a societal level. And this issue is really a reason to pause and reevaluate whether there are other neuroimmune drivers at play. And as we consider the many critical neuroimmune interactions that exist in neuropathic pain, it's increasingly clear that sex is a really important factor we need to understand. So this diagram is a bit complicated, but I'm showing you some key anatomical landmarks in the pain pathway and the immune cells that interact at these locations. There are multiple inflammatory pathways that we know impact pain in a sex-dependent manner, but I want to specifically draw your attention to the microglia, where it's become clear that activity in these cells is required for pain in male rodents, but not in females. And you can see that represented by the exclusively blue triangles in that cell. And so this translational issue is compounded by our knowledge that microglia involvement is sex dependent, and that highlights the need to consider sex as we explore other neuroimmune mechanisms. And so to summarize, we really have a twofold challenge. One being that our research into microglia hasn't proved to be translatable to patients, and two, that we have inadequate coverage in our understanding of the female biology, which exacerbates our clinical translation issues. So today I'm going to tell you about how we're tackling both of these challenges by exploring alternative neuroimmune mechanisms in neuropathic pain and specifically focusing on understanding sex differences. And part of the challenge for achieving our goals is the current available rodent models for exploring neuropathic pain. So neuropathic pain is most commonly modeled in rodents using traumatic injury to the sciatic nerve, and that evokes a robust microglia response in both males and in females. And so to examine alternative neuroimmune mechanisms, we also need alternative tools. And so I'll tell you about the model that we've characterized in our lab, which uses a tissue called nucleus pulposus. And the model is illustrated on the right, where you can see that the NP tissue is placed adjacent to the sciatic nerve. And I'm going to take you through some of the key characteristics of this model that are critical to our research. So firstly, the NP model shares all the characteristic behavioral changes we see in standard models of neuropathic pain in rodents. The graph on the right shows mechanical sensitivity in rodents that receive the NP tissue or a sham surgery. We measure mechanical sensitivity using something called a von Frey assay, where filaments of increasing force are applied to the paws of the animal. On the y-axis of the graph, higher values indicate that the animal is less sensitive, and lower values indicate the animal is more sensitive. And you can see that when the NP is applied in both males and females, there's a robust and persistent hypersensitivity compared to the sham. And we found similar increases in sensitivity for hot and cold stimuli as well, all of which are characteristic of a state of neuropathic pain in rodents. And these pain-related behaviors occur independently of a microglia response in the spinal cord. So these images are showing you the spinal cord stained with IBA1, which is a marker for microglia. That very bright spot you can see on the left side is the typical microglia response in standard neuropathic pain models, and it's absent in the NP model. And when we apply inhibitors of microglia that typically reverse sensitivity in the standard models, there's no impact on the behavior in the NP model. So what we're working with is a microglia independent model of neuropathic pain. But then we still have the question that if it's not microglia as the driver, then what is it? And when we looked more closely at changes in the sciatic nerve, we can see robust macrophage infiltration to the sciatic nerve. You can see that in panel A with the green F480 staining, which is a marker for macrophages. In panel B, I'm showing you the results for mechanical sensitivity in an experiment where the macrophages have been depleted. And when we deplete the macrophages, the mechanical hypersensitivity is also abolished. So the model of microglia independent neuropathic pain is actually dependent on these macrophages. And so these findings give us insight to some of the peripheral mechanisms and activity in the model, but they don't give us the full picture. We're still needing to understand how we get from the periphery to the central nervous system, where signals are first processed at the level of the spinal cord. And to do that, we've investigated a two-part mechanism in the spinal cord that's a known convergent point of alternative forms of neuropathic and inflammatory pain. So in this figure, what I'm showing you is a feed-forward loop in spinal neurons that produces an enhanced excitatory state. This first happens with the downregulation of KCC2, which inhibits inhibitory signaling. And second, via the phosphorylation of NMDA receptors, which enhances excitatory signaling. So both of these changes produce a state of hyperexcitability, which amplifies pain signals. And I'll show you some preliminary data from experiments where we've targeted each of these components. So first with something called CLP290, which restores KCC2 function. And second with APV, which blocks NMDA receptors. And this is data for mechanical sensitivity in both experiments. As before, the lower y-axis values indicate increased sensitivity. In panel A, you can see that when we apply CLP290 to enhance KCC2, that moderately reverses hypersensitivity. And in panel B, when we apply APV to inhibit NMDA receptors, it robustly reverses mechanical hypersensitivity. So there seems to be a role for both of these mechanisms in the spinal neurons, despite the lack of microglia involvement. And how that comes about is really the focus of what we're doing now, to understand what mediators are involved in bridging what we see in the periphery to changes happening centrally. And I'll end with some very preliminary data to show you one of the avenues that we're pursuing now to better understand this mechanism. And this is an inflammatory signaling pathway that is centered around a protein called Gasdermin D. And I can tell you a bit more about that if you're interested, but very briefly, Gasdermin D is responsible for regulating the release of multiple key inflammatory mediators from cells. And so we've started exploring this model in Gasdermin D knockout mice. And we found that in Gasdermin D null mice, we don't see the full extent of hypersensitivity that we see in normal wild type mice. But in female mice, there's no difference between the genotypes. And now this is the first place that we've seen the sexes diverge in this model. And so we're looking forward to further disentangling this mechanism and the sex-dependent role of this protein to more completely understand the mechanism in both males and in females. And I'll just thank my supervisors and my lab members, and thank you to the organizers for letting me present today. I'm really appreciate it.
How do you see these new mechanisms, new findings from your research being translated, or what do you envision that happens after you have the definitive findings in terms of moving forward research or even clinical practice, if there is opportunity to reach this knowledge?
Sure. So this is very, very early stages, so I probably won't push my predictions too far. But I think one of the key things with this, as we just try to understand this model, is that we're trying to build something that is more reflective of a clinical state, as we've seen this disconnect between what these standard models that have been used for many, many years now has not helped us move forward in terms of what we're able to do clinically. And so we want to build something that is more reflective, because we hope that when it is more reflective, when we find things that are critically involved in these mechanisms, the important components of these mechanisms, we find targets for drugs and for therapies. So again, this is very early stages, and clinical translation takes a long time, but we're hoping to build the foundation of something that is more reflective and then use it to identify therapeutic targets.
Maybe your work will inform even further research with better models.
Absolutely.
For like neuropathic pain.
Absolutely.
Hi, everyone. Before I begin, I'd really like to thank the organizers for inviting me to speak today. My name is Vina Mohabir, and I'm a PhD student at the Institute for Health Policy Management and Evaluation, and also a PhD student in the IOUCH lab with Dr. Jen Stinson. I'm going to take a little bit of a different approach today and tell you a story. So the story I want to tell you is the story of Sai. Sai is a non-binary teen who just started grade 9. They're proud to be Afro-Caribbean and from the beautiful country of Trinidad and Tobago. Sai noticed themselves feeling off, but they assumed it was the same tiredness and pain, constant aches as usual for them, so they brushed it off. Their teachers were already policing them about their absences in classes, so they decided just to keep pushing through it and make it through the school day. It was a cold fall day, and Sai's mom had the night shift. So that meant that they were taking transit to school. While Sai was waiting at the bus stop, they began to get short of breath, experiencing sharp stabbing pain in their chest. Sai was worried, but didn't want to add to the stress of their family. Luckily, on their walk to school, Sai's sister Patrice noticed her sibling having trouble breathing. She knew calling their mom wasn't going to help since they were on the warehouse floor and not allowed to have their phones. She looked at Sai and said, "By the look on your face, we have to go to the emergency department. But before we go, I want you to remember that people die here, not because their condition isn't treatable, but because of their color of your skin. You have to act differently. Don't speak with your accent. Do not ask for opioid pain medication. And whatever you do, don't tell them mom isn't with us." Sai was confused about this information, but knew their sister had accompanied their mom to the ER many times. Why is it that the people that are supposed to help and heal you are actually trying to harm you? Sai tried their best, but when they arrived at the ER, they were in such bad pain, they were begging for anything to help. A nurse came in the room and said, "Just take some deep breaths, you'll be fine." But Sai's sister, knowing the pathway of a lot of youth with sickle cell disease, said, "No, Sai needs pain medication." Unfortunately, this led to Sai and their sister overhearing outside a conversation between a nurse and a doctor, where the nurse said, "I have a difficult Black kid who's not listening to me. I think they're just here for painkillers." And the doctor replied, "Well, the boys shouldn't eat as much pain meds. Black people don't feel pain the same way. In fact, their skin is thicker." Not only was this racism, but on top of this, Sai was misgendered. At this point, since Sai wasn't receiving any help due to discrimination, they decided to tell their sister, "I'm not safe here." And as Sai began to get up, they went into cardiac arrest. A team of nurses and doctors surrounded Sai's bed and called for a code blue. Patrice stood there confused, and she was unable to identify what was happening with her sibling. She was horrified and realized it took Sai almost dying for them to take their pain seriously. It wasn't until they met an amazing doctor named Dr. Sarah Muhammad. Sai was then diagnosed with sickle cell disease. Dr. Muhammad explained to Sai that the circulatory system, which is a highway that transports all your nutrients, bloods, everything important to you, has, in your case, sickle shaped blood cells. And that means, like the 400, there are traffic jams which cause vaso-occlusive crises. Sai had heard of this back home in Trinidad, but people really didn't talk about it. She told Sai about the causes and the many chronic and life-threatening complications like stroke, organ damage, and severe anemia. She also said that approximately 30% of youth with sickle cell disease live with daily pain. So I looked at Dr. Muhammad and said, "Dr. Muhammad, I need you to be honest with me. In the ER, they said I was there for just drugs." is this really that bad of a pain? Dr. Mohammed told Sai, well, people have said that the pain from sickle cell disease is worse than childbirth and just as bad as terminal cancer pain. So yes, you do need pain medication and treatment for this. Sai was miserable. How are they going to achieve their goals? How are they going to reach any of their aspirations? So luckily, a kind nurse walked into the room and started to give Sai and their sister information about sickle cell disease. And Sai's sister was still not pleased with the information. It was outdated, it was on paper, and really didn't help them with their day-to-day management of sickle cell disease. So this nurse, luckily, attended a lunch and learn, which we have lots of here at Sick Kids. And what they ended up learning about was this app called I Can Cope with Sickle Cell Disease, which was just proved effective at helping reduce pain for youth with sickle cell disease. So in this case, Sai began to use I Can Cope with Sickle Cell Disease, and they found it really helpful in managing their day-to-day condition with check-ins. They found it great to set goals related to their condition, and especially with pre-made goals that a lot of other youth find helpful. A whole library section that was online on their phone that was really easy to understand, and a community section where you had a chance to interact with other youth with sickle cell disease. Unfortunately, though, Sai was still thinking about their emergency room visit and wondered how could they potentially get support for this important issue. So Sai is right. We have to address the racism, systematic oppression, colonization, and white supremacy embedded in our systems today. But people like Sai need help right now. So it's incredibly important to understand what stigma is, which is a social process which involves evaluation, exclusion, and discrimination of an individual based on groups or group identities or just their identities alone. There are different types of stigma, including racial stigma, internalized stigma, which is where you start to internalize those values that society holds into yourself and start believing they're true. There's structural, societal, social stigma, and these are just a lot of ways of saying in that experience that Sai had, Sai experienced multiple forms of stigma. And even just the anticipation of going into a healthcare environment caused actually anticipated stigma. So it doesn't even need to occur in a healthcare setting. It can occur even before they actually make it. There are some related concepts to this, such as injustice, discrimination, exclusion, racism, sexism, classism. And as you can see, they are all interrelated with each other. In 2019, Health Canada actually declared stigma as a public health priority, which meant that us as researchers, clinicians, people with lived experience, were called to action to start to develop ways that we could actually start beginning to address stigma. And despite this being a critical issue, unfortunately, no evidence-based interventions have been developed for youth with sickle cell disease, especially through an intersectional lens of stigma, which accounts for multiple forms of stigma that an individual may experience. So what we are doing in the IH Pain Lab is co-designing and completing an evaluation of a stigma intervention for youth with sickle cell disease. This intervention will be equity-centered with an anti-oppression lens, so thinking about those systems of oppression and the layers of oppression that different people go through, and justice-focused, so focused on making changes that actually reduce that feeling of injustice a lot of people in the healthcare system experience. So this will be a phased approach, and the first phase involves a scoping review to start to identify what intersectional stigma looks like, what kind of research people are doing in this area, in addition to doing a systematic review of the different forms of stigma reduction interventions for other pediatric chronic health conditions and learning from other fields of study, breaking up that silo. Phase 2 will involve an equitable co-design process with clinicians, researchers, and youth living with sickle cell disease. And using that co-design process together, we will develop a stigma reduction intervention, leveraging the existing components of I Can Cope and developing specific content for each of those features within the app. Phase 3 will be a mixed methods evaluation. So the first phase will be testing that in a randomized control trial and looking at simply feasibility of an intervention like this. And then after which we will be doing qualitative interviews to learn more about the experiences of youth using this intervention, as well as how they felt about it. Because really, as I said, underneath phases, this is all directed and guided by people with lived experience. Thank you so much for listening to my presentation today. I'd like to acknowledge Dr. Jen Simpson, Dr. Chichalalu, the lab, and as well as the CIHR project grant that is also why I'm here today. Thank you.
Questions?
Thank you so much, Vina. Did you say that there are no known interventions to alleviate stigma?
In sickle cell disease, yes.
Right. Are there interventions for stigma in other clinical conditions or whatever that you feel that will be relevant? I mean, what are your kind of anticipated results? Thank you.
Thanks, Fiona. That's a great question. Luckily, part of grad school and working with a great supervisor is they throw you right into what you're doing. So I've already started a scoping review of these different interventions that exist and potentially different disease conditions that we can learn from. One of these areas is HIV. They have a ton of literature on stigma reduction interventions as well as mental health. So there's a lot on mental health stigma as well. So hopefully we can learn from these two areas as well as exploring, additional areas that I may not have even considered due to my biases or whatever that may be, and really go through the literature in a systematic way to ensure we're capturing kind of all the great resources out there. And from there, we're going to present that to the youth advisory, and they'll kind of direct where we go with all that information. Thanks, Anna. Yeah.
It seems like all of your work is really driven by patients and lived experiences and families with youth and children in those positions as well. How do you plan to engage this youth, but also being mindful of their own awareness and making like a safe space and giving them opportunity to talk, but also feeling, protected and secure?
Thank you. That's such a wonderful question. And it's something that keeps me up at night. Like, how can we do this in the best way, in a way that makes people feel included, engaged, and safe, most importantly, and prevents re-traumatization? So I'm, again, incredibly lucky to work in a great lab where lived experience is fundamental to everything we do. So we actually have already engaged patient partners and community organizations on, and if you were here this morning, your landlady from the Sickle Cell Association of Ontario, they're a partner with our lab and on this project as well. So, I think I spoke about this yesterday a bit, but it really is going slow, meeting the people where they're at, understanding that we represent an institution that has brought harm to them more than we have brought healing. So in these cases, it's incredibly important to recognize that and own that as part of the history, and also own what's currently happening in our systems and not being part of what gaslights them into believing that these experiences are non-occurring or internalizing these experiences. So I hope, I feel like, the best thing would be to have a patient partner up here so they could share their experiences. But in lieu of that, I can say that, the patient partners we work with are incredible. They're full people with skills outside of just managing their condition. And I think what's really amazing is learning about what they would like to do and things that they're interested in. One of our patient partners loves social media, wants to make TikToks for this and things like that. So it's really also about finding spaces where we can make sure they feel valued and seen as a full member of the team, just like anyone else.
So I think that's a wrap for this session, everyone. It was really a pleasure to see all this amazing work. I always say that the future is bright for the Canadian pain landscape with these amazing trainees that we have. And thanks again for the opportunity of being here.